Hello, I'm Blanca del Pozo from Western University. I'm a clinical pharmacology fellow, and I'm going to present the results of our recent retrospective study regarding Rett syndrome. As you know, drug reaction with eosinophilia and systemic symptoms is a severe cutaneous alveolar drug reaction, which is characterized by generalized skin rash, fever, lymphoadenopathy, hematologic abnormalities, and systemic involvement. Despite that nowadays exists several scoring systems to diagnose more effectively this condition, the proper diagnosis of DRESS continues to represent a challenge in the clinical practice, mostly due to the fact that many of its clinical and laboratory features are similar to those present in other infections or inflammatory conditions. Therefore, we decided to perform a retrospective study to identify the most common features of patients with DRESS seen in our center. As you may know, until a couple of years ago, DRESS did not have a specific code in the ICD coding system. So to identify these patients, we review all inpatients with codes related to alpha drug reactions or eosinophilic syndrome seen in our institution over the last 10 years. We only include patients with registrar score higher than 5, which defines a definite case of DRESS. Of 311 charts reviewed, 30 cases were identified as a potential risk, but only 19 patients were included, 4 children and 15 adults with an age range of 4 to 76 years. Unlike other series, in our study, antibiotics were the most common culprit drugs, followed by anticonvulsants. Patients with chronic infections receiving long courses of wide-spectrum antibiotics were the most frequently affected. Regarding clinical features, the skin rash usually presented a couple of days before the hospital admission, with a median time of presentation of 3.7 weeks after the drug exposure. The phenotype described in more than half of these patients was a generalized skin rash and facial edema, and fever and malaise were also very common. In addition, mild to moderate elevation of liver enzymes was present in most of our patients, but only 4 had severe liver injury, while renal involvement was present in only a few patients. An interesting finding was that although cardiac symptoms were reported only in 4 patients, elevation of the troponin was reported in twice as many. This suggests that cardiac involvement may pass unnoticed in many of these patients. All our patients had eosinophilia, but only 95% of them had counts above 700 cells per microliter. Interesting, at the time of admission, only 14 patients had eosinophilia. Atypical lymphocytes were observed in 1 out of every 4 patients. To understand the evolution of this condition, we estimated a time life of key features after the exposure to the trigger drug. In this graph, we can see how the skin rash in blue and the renal damage in red presented simultaneously almost at the same time, while the elevation of the liver enzyme in yellow seemed to concur with the first count of eosinophilia that presented several days later. Similarly, we can see how the cardiac damage in green presented almost a little bit early than the highest peak of the eosinophils that was presented many days later after the beginning of the cutaneous manifestations. Regarding treatment, systemic steroids were used in most patients, but the type and dosage of these treatments were different among them. Therefore, no conclusion could be made. Overall, the recovery time was 2 weeks, and there was only 1 death. In conclusion, the diagnosis of DRESS should be considered in any patient with generalized skin rash accompanied by fever, systemic symptoms, and a relevant medical history, taking into account that some of the key features may not be present at the same time. Identification of these key features and close monitoring for any additional organ involvement are required in order to improve the care of these patients. Further prospective and collaborative studies are needed to have a better understanding of this condition. Thank you for your attention.